And then we talked about the myelodysplastic and the myeloproliferative stuff. Let's just do a real quick review of some of that stuff. Then we'll jump into the leukemias. So myeloproliferative, what are we talking about? Myelofibrosis, polycythemia vera, essential thrombocythemia, right? And the last one, CML. What's the problem set in all of those? What's the common problem set? Tyrosine kinase, right? JAK2, Janus kinase, right? They all have a similar problem set. And it just depends on where that Janus kinase is turned on, right? So what does the tyrosine kinase do? It's that on switch to tell the cell to divide. You gotta be able to. So polycythemia vera, all your cell lines are increased, but which one is more increased than the others? Red blood cells, your problem cells, your RBCs. So all the disorders and all the symptoms you see is a result of these increased RBCs. Essential thrombocytosis, essential thrombocythemia, whichever term you use, what's your problem set? Increased platelets. CML, what's your problem set? Chronic myelogenous leukemia, the myeloid cell line. So your WBCs, right? Your neutrophilic cell line, neutrophil, eosinophil, basophil, right? And then what was the other one? Got them. And then myelofibrosis. What's going on with myelofibrosis? Yeah, so myelofibrosis, the problem sets right within the bone marrow. And then the megakaryocytes are putting out these growth factors, forms a collagen inside the bone marrow that now crowds out the bone marrow. You get a fibrotic bone marrow. So you can't produce the other cell lines, so you end up with a cytopenia of some kind. I'm gonna see. I'm gonna keep my fingers crossed. Do one of these things actually work? Do we have something that works? Oh. Still nothing? All right, so hey, let's back up for a second too. I want to talk about the myelodysplastic syndromes for a second because this is going to tie into the leukemias. So, what did we say cancer is? What was cancer? Uncontrolled growth, right? So, and I said, think about this in a simple way in a two-step process. You have a mutation that produces an abnormal cell. You have a second mutation that now tells this cell to proliferate or to grow uncontrollably. Right? Now that's cancer. Right? We're going to talk about the leukemias in a second, right? So what's leukemia? Right? So most people, I won't say most people, I know I did, right? When I hear the word cancer, right, we think tumor, we think of this mass, right? In this case, it's not a mass, right? It's a cancer in your blood. I'm going to have faith that one of this is going to, yes, this looks like color. All right, so MDN, right, are, if you're old like me, MDS, right, myelodysplastic neoplasm, myelodysplastic syndrome, right, is the whole terminology that we use. So kind of what's going on, right? So we know how blood cells get produced. This is actually like, okay, I thought it was a Sharpie for a second. All right, so you have a hematopoietic stem cell, right, that produces whatever, other cells, right? So a normal cell line kicks out an immature cell, a blast, and then a couple other down here turns into a mature cell. Right? Blast goes through a series of whatever, becomes a mature cell. When we say a mature cell, what are we talking about? We're talking about a differentiated cell, a cell that now has a function and is able to do whatever that function is. Right? If it's a white cell, it can fight infection. If it's a platelet, it can clot. If it's an RBC, it can carry hemoglobin. You have a mature cell. Right? So MDN, you got these hematopoietic stem cells that kicks out a normal one, sure, normal mature cell. And then one day it kicks out a funky looking cell. It now has this blast cell that's undergone this mutation. And this mutation, right, kind of think of definition of cancer for a second, right? Abnormal, so I produce the abnormal cell. And what happens is, it stops right there. It doesn't go any further. It's stuck in the blast phase. Okay? And that's MDN, myelodysplastic neoplasm. So abnormal cell stuck in the blast phase. It doesn't progress. It doesn't mature. All right. Everybody with me so far? You got a white people?
Yes.
No? So this is why, and you'll see when we talk about the leukemias in a second, just remember that. But before we do that, so again, you take all right, that's somebody's bone, right? You got it. You do a cross section of the bone. You're looking in on the marrow. Right, that's where that hematopoietic stem cell that we were just talking about, kicking out all your cells, right? So now, normally you got all your precursors in here, right? Your stuff that's gonna turn into WBCs and RBCs and platelets and all this crap. But you're putting out all these abnormal cells that are stuck as blasts. Everybody still with me, right? So all these abnormal, funky looking blast cells start to crowd out the bone marrow. So now, going into circulation, because all these abnormal blasts are here, means I get less RBCs. If I get, right, because I can't produce as many RBCs because these blasts are crowded out the bone marrow. I can't produce the platelets, so my platelets go down. Right? So when you review your MDN, you're going to see the hallmark of MDN is going to be some cytopenia of some kind. 85% of the time, it's going to be anemia. Because the bone marrow gets crowded out, I can't produce as many RBCs, they become anemic. Right? You're going to see about 50% of the time, it's thrombocytopenia. Right? Bone marrow crowded out by these blast cells, I can't produce the platelets. Right? And then I think about 25 to 50% of the time they get neutropenic. Right? I can't produce the white cells, mature white cells. That's MDN. Everybody kind of with me? Seriously. Okay, and this is going to matter to you now because we're going to talk about the leukemias. What did we say cancer was? Two-step process kind of thing? Again, keeping it simple, right? Think of it as a two-step process. What's the first step?
Mutation.
A mutation. A mutation that produces an abnormal cell, like we saw with MDN. And some people look at MDN as a precursor to the leukemias, to cancer. So again, MDN, hematopoietic stem cell in bone marrow, kicks out a blast cell, right? Normal blast cell, and kicks out an abnormal blast cell that's stuck in that phase, MDN. This cell now, that's mutation 1. This cell now undergoes a second mutation, right? And this mutation tells this cell now, I want you to replicate. I want you to produce more of you, right? And you just start producing crazy amounts of this abnormal cell. That's cancer. That's leukemia, right? So you've taken that MDN, that one abnormal cell, and now I've added another mutation that causes it to replicate. And that abnormal cell grows uncontrollably. Everybody with me, right? If you got that, you're halfway home. Like this lecture, we're done already, right? So we're going to talk about it, and we'll run through the slides here, right? But let's just kind of get the ground rules. So the leukemias come in a couple flavors, right? Acute, and then the chronic. Anytime you hear acute, think sudden onset. It's rapid, right? Chronic is more of an indolent thing, right? It's there. And when you hear acute, think immature cells. And what I mean by immature cell, what's an immature? Give me an immature cell. Blast. Exactly. So when you hear acute, think immature cells. When you hear chronic, think of mature cell. Okay? Again, two flavors, right? Myeloid versus, what's the other cell line? Lymph, right? And those are your hallmarks for your leukemias. An acute myelogenous leukemia. It's acute, so it's going to be what? Blast, right? And when we say blast, if you look at the slide, if you look at a bone marrow aspirate, if you look at a peripheral smear greater than 20%, right? Greater than 20% blast defines an acute leukemia. In MDN, you saw, hey, the cell got stuck in a blast phase, so you're going to have an increased number of blasts, but it's going to be less than 20%. Because the second you tip into that greater than 20%, now you're talking about a leukemia. Okay? Everybody with me? Is this making sense? You guys saying that so I feel better after the test? You serious? Sorry. So we are the largest PA school in the world, and we are a resource that's not the largest PA school in the world, right? So again, the leukemias, right? Acute, right? And under acute, you have AML and ALL. Acute myelogenous leukemia, acute lymphoblastic leukemia. Okay? Chronic, what do we have? CML and CLL. As we go through the slides, pay attention to the age distribution. It's going to matter. ALL is almost always children. CLL is your most common. Pay attention to your age distribution as we go through this. I'm going to run through the slides. Right? Just kind of keep in mind what we just talked about. It will help this kind of make sense. If you're able to follow what we're doing. If you can't follow what I just put up there, come yell at me. Right? Because you need to have that basic understanding when we talk about the cancer. So again, just keep in mind, right? Sort of think of it as this two-step process. Abnormal cell, got it. And something else kicks into that abnormal cell, a second mutation that causes that abnormal cell to proliferate and grow out of control. All right, let's run through the slides. Nice and slow. AML, there are your subtypes we talked about. All right, so leukemia. All right, kind of what we just talked about. This malignancy, these hematopoietic stem cells, got it. Overproduction of an abnormal cell. Acute, rapid, immature, blast greater than 20. All right, so also should sound familiar. Chronic, gradual, persistent. Blast less than 20. The second my blast hit greater than 20, I'm now dealing with an acute process. And lymphoid versus myeloid lines. Good to go. There you go. Again, the epidemiology. All children, however you want to remember that, but ALL is typically considered a disease of kids. All right. So, excuse me. AML, old age, ALL, kids. Kind of like that picture of the bone marrow, right? I gotta figure out how to get on that thing, but nobody can seem to get that to work the way I want it to. So we talked about with MPN, you start to see the cytopenias because the bone marrow gets crowded out, right? Everybody good? Everybody give me a head nod, make me feel good about myself? All right. So similar thing happens with the leukemias, right? Even more so. Again, that bone marrow, you're having what? An overproliferation of all these abnormal cells. So my bone marrow gets super crowded in a hurry, right? There's only so much space in the bone marrow, right? And cells need all those nutrients to grow and do and replicate. I only have so many growth factors, so many nutrients, right? So these abnormal cells start to take up the bone marrow. So again, I get a decrease in my RBCs. All of a sudden now, I start putting out less RBCs because my bone marrow is filled with all these abnormal, immature cells. Good? I put out less platelets, right? So my patient becomes what? I'm low on RBCs. What does that make me? Anemic. I'm low on platelets, all right? I got thrombocytopenia, which, how does that manifest? Some sort of bleeding issue, right? Now the WBC count. Your WBC count, what's your WBC count? What happens? High, low? Variable. Good answer. All right, don't get tripped up on this. So your WBCs, right, because eventually your bone marrow gets crowded out, I start to see less WBCs in circulation, right? So maybe they're low. At some stage, all those WBCs, abnormal, whatever, they're gonna start spilling out of the bone marrow. And then my WBC count could be normal, or it could be way off the chart, super high. It depends on where they are in the disease process. Okay? Everybody good with that? So they tend to become anemic and thrombocytopenic, and then their white cells are variable, just depending on where they are in the disease process. All right, there it is. AML, myeloid precursors. Accumulation, yes. Myeloid, yes. R rods, we're going to talk about R rods. R rods are azurophilic granules, right? They're cytoplasmic inclusion bodies inside the cell. How are you going to know that? How are you going to know they exist? Differential, right? Again, some poor chuckle lab tech gonna sit there staring on his microscope. He's gonna do his differential, and he's gonna note these inclusion bodies. And when you get your differential back, it's gonna say, hey, 1 plus, 2 plus, whatever, our rods noted. If you see our rods, right, you are dealing with that disorder. Thanks question, right? You see our rods, right? That's pathognomonic. All right. So again, going to our leukemia, impaired production of normal cells, right? Kind of walk the dog on why that happens. They become anemic. Again, bone marrow gets crowded out, they start putting out less RBCs, they become anemic. Bone marrow gets crowded out, they start putting out less platelets, they get thrombocytopenic. All right. I hate stuff like this. So World Health Organization classification of all kind of million guide. We're going to talk about a couple of these specifically. We'll mention that one. We'll talk about Down syndrome a little bit, maybe. All right. Don't try to memorize it like every type of leukemia on the planet, right? That's not what this is about. All right. Most common AML variants, yes. So again, these are just a couple variants of AML. When you see T, talk about translocation. All right. So translocation, spots on a chromosome. The one here that I want you to be familiar with, we're going to talk about, and that's the acute promyelocytic leukemia. 5 to 20% of all AML cases. What's the promyelocyte? Let's start there. So we just talked about leukemias and we talked about blast cells. We talked about immature cells. we said that this is an acute process, so we say it's an immature cell, but now I didn't say blast, I said promyelocyte. So if you go back to our rainbow chart, right, of our cell lines, right under the blast phase, you get promyelocyte. So you get a myeloblast and you get a promyelocyte. So it's still a very immature cell. It's much closer to being a blast than it is to being a mature cell. Okay? So that's your promyelocyte. Yep, slightly mature than true blast, got it. And we talked about these azurophilic granules, the hour rod bodies. The other thing to note about these things, they're procoagulants. Right? So they increase this clotting and puts the patient at rest for DIC. I said it, my conscience is clean when you guys missed that on the test. Right? Highly curable. That's the other thing to note about this one. Right? Because of the method behind it, it has to do with vitamin A, retinoic acid. It's readily treatable with simple vitamin A. All right. Oh, yeah, it's in there. Perfect. So, hey, again, myeloblast, promyelocyte. Much closer to being immature. Really, it's an immature cell, right? Just slightly more mature than your blast. And it's a long way from being a mature cell. Acute promyelocytic leukemia. All right, AML, other one that we were going to talk about. So very aggressive form. And this kind of goes back to something we keep mentioning. No treatment is completely benign. Right? Chemo, radiation. So a lot of times we give these patients, and we cause this, I say we, right? We healthcare providers, whatever. But because we've initiated some chemo, some radiation, what does radiation and chemo affect?
Cells.
Yeah, cell, it affects DNA, so it causes a mutation that sets them up for AML. And this is what you're talking about here. All right. Most common acute, right, in adults. Risk factors, we mentioned the chemotherapy, environmental toxins, short benzene, and Down syndrome, so genetic predispositions. What's Down syndrome? Trisomy of 21, right? So the jury is still somewhat out on this, but the thought process behind this, because you see this a lot, where Down's patients, very, very high risk for a lot of the cancers, right? And part of the thought process is, so with the trisomy, they have an extra chromosome 21. There is a protein that chromosome 21 puts out that actually affects DNA. And because they have this extra chromosome, there's more of this protein being produced that's affecting the DNA that's causing these mutations. That's sort of the pathophysiology behind that, at least one of the going theories currently. We just understand that, hey, Downs, they tend to have a high risk of a lot of cancers. All right, so AML, male predominance, and then age. What's the age we're looking at here? Older, right? So again, AML older, 60s, 70s, and there's a male predominance for the AML. All right, kind of what we talked about. Symptoms, you get the cytopenias. Anemia, we know what anemia looks like. Thrombocytopenia, we know what that looks like. Bleeding, purple, whatever. Neutropenia, right? Everything gets crowded out. Now there's not producing these mature cells. So you said the white count is high, right? So let's say the white count is high. Could they still be neutropenic? Yeah, could have a lot of super immature cells, right? If they don't have mature neutrophils, then they're neutropenic. Right? And what do neutrophils do? What's the job of the neutrophils? Fight infection, right? So again, recurrent infections because they're neutropenic. Ah, this is terrible. I think I'm allergic to you guys. All right. specific features, gum hypertrophy, so monocytic variants, and that's what that looks like. And of course, they can develop some hepatomegaly and splenomegaly. Crap. All right. So lab findings, we talked about this, right? Again, right? So this is like 4 times today we're talking about these lab findings. Anemia, thrombocytopenia, the variable white count. Can everybody wrap their head around why the labs look like they look? Bone marrow crowding out everything. I stopped producing a lot of RBCs, I get my anemia. Stop producing my platelets.
Does a white blood cell count, as it leaves out, like you said, does it correlate with the progression of your leukemia? Or is it variable depending on the person?
So there's some variation, but if you see a lot of blasts, right, so it's creeped out now in the system and now I have greater than 20% blast, that's bad, right? When they get into the acute phase, and when we go over CML, actually we did CML the other day, right? So triphasic disease, right? So you have the chronic phase where they're just coming along, they get accelerated, you start seeing an increase of blast, and then the acute phase where you get over 20% blast. Those are bad prognosis, right? And the idea is if you can catch them when they're in that chronic phase and treat them, then they don't progress, right? But once they get into that acute phase, badness pursues, right? All right, so there you go, peripheral smear, we said, right, the greater than 20% blast. Our rods we mentioned, pathognomonic for this disease. Right? I see our rods, right, my differential now narrows. This is what I'm dealing with. Bone marrow. Hypercellular, yes, got it. Again, why the elevated uric acid?
You're destroying a lot of white blood cells.
Yeah, so that's, you have a high turnover, you're producing all these cells, right? And then as they break down, you get the uric acid from the DNA. All right, let's talk about this last 2 terms on here. Cytogenetics, flow cytometry. It's on here. Don't try memorizing whatever the hell that all means. All right, we'll talk about the significance of what this is. And this is the thing with cancer these days, right? Cancer treatment is very targeted, very specific. And these are markers that they can find on a cell. So they say, okay, the cell has a certain marker, this is the characteristic, this is how we need to attack it. Right? And that's why they do these. So cytogenetics, right? Chromosome, and you figure out the aneuploidy, right? Aneuploidy, is there something abnormal? Instead of 46 chromosomes, do they have 45? Do they have 47? Whatever. And then immunophenotyping is kind of there with the flow cytometry. Again, it's just a way for them to figure out more, right? These cells have specific markers, and you can really narrow it down to, yes, it has this TDT, whatever marker on there, it's CD, whatever, right? Way beyond what we need to know, but just kind of understand the concepts behind them. Cool? Unless you guys want me to include some of that stuff on there, but I don't know about that. All right, fair enough. And then, hey, so again, your R rods, that's what it looks like up close. Pathognomonic for AML. Therapy. Again, we are primary care guys. What's our job when it comes to cancer? Our number 1 job is prevention. Right? So again, sometimes it's just educating your patient. Hey, knucklehead, stop smoking, right? Hey, you might want to reduce your drinking, right? Because again, all right, more and more they're identifying links between alcohol consumption and cancer. So again, for us, we try to educate our patient, try to prevent. Then what? What's our next step? Screen them, right? We try to prevent. If we can't prevent, we screen them to see, hey, you're increased risk. I want to see if you have cancer. And then what comes after screening? What goes hand in hand? You screen them, you diagnose if they have it. If they got something, oh crap. Now what's your job? Refer the hell out of them, right? It's not our job to initiate that cancer treatment. Cancer treatment is just so specialized. right? You see the flow cytometry, all the specialized testing that somebody way above our pay grade is gonna figure out, and figure out what your treatment protocol should look like. Right? All right. Targeted therapy, sure, 7+3, this is, they get 7 days of this chemotherapeutic drug, and they get like 3 days of infusions with that one, that's what I'm referring to. Targeted, we mentioned APL, what's APL? Acute promyelocytic, right? So, right, vitamin A. And then, yeah, induction, consolidation, if you go back to the day one slide, right, we talk about the treatment, just kind of have an idea of what that is. Right? Induction, consolidation. Good, and then tumor lysis, we'll talk about in the last lecture. And tumor lysis is a complication sometimes of treatment, where you lyse the tumor cells and then it releases everything to the system. If that is pursued, so we'll talk about that more. Prognosis, 5-year survival, 30%, yeah, better outcome, younger patients, sure. AML, acute myelogenous leukemia. Again, when you get stuck, go back to the definitions. Acute means what? Immature cells, quick onset, right? Myeloid, you know what cell line you're dealing with, right? Everything that's not a lymph, right? All right, ALL, acute lymphoblastic leukemia. Acute, therefore, what are we talking about? Blast, right? All right, well, T cells or B cells? Right, because our lymphs come in 2 flavors. How we doing on time? How much? 17 minutes? Are you lying? There's no break. There's no crying in baseball. There's no break. I have you guys still kind of through? Sure? I gotta get through this lecture today. You guys set me back. I don't like this class anymore. Alright, so talking ALL, acute lymphocytic leukemia, right? You have B cells and your T cells. It's my fault. Why are you always blaming me? I noticed that. You could have blamed me. Alright, so let's come in 2 flavors, T cells, B cells, right? T cells, when they leave the system, right, they leave the bone marrow, where do T cells go? Thymus. And which patient population do we see this in a lot? Teens. T cells, thymus and T. B cells are going to come in different flavors too. So let's see, you got the translocation 12, 21, which you will see with children. I'm going to nerd out on this too much, we'll talk about this. And then you have the translocation 9, 22, which you see with adults. All right. See the look of confusion on everybody's face, my handwriting. All right, the takeaway here, right? Come in 2 flavors, T cell, B cell, T cell, big thymus, thick teens. AL in general is who? What's our patient population? Children, right? You have a couple different variants, and you don't gotta nerd out on the variants, right? That, I'm gonna confuse the hell out of you guys, so I shouldn't probably teach you this, but I feel like I'm not doing my due diligence if I don't mention it. So see this and then forget it. Alright. This variant here is the same as the Philadelphia chromosome. Now I'm gonna tell you to forget that. Alright, but that's a very, very rare occurrence. Anytime, test world, real world, you see the Philadelphia chromosome, what disease disorder are we talking about? CML, right? But that's the hallmark of CML, the Philadelphia chromosome. But you do have this weird variant with ALL. All right, so ALL, B cell, T cells. Again, we're talking about this sort of the same sort of disease process that we just did with AML, but instead of it being the myelogenous line, now it's lymphocytes, it's a lymphoid, it's lymphoblast. So where before I was seeing myeloblast, now the problem we said is lymphoblast. But at the end of the day, it presents similarly, right? Because what happens, the bone marrow gets crowded out by lymphoblasts. So I stop producing my RBC, so I become anemic. I start producing less platelets, I become thrombocytopenic. Right? I'm crowding out all my other white cells at the expense, right? So all these lymphoblasts, so I become neutropenic. Is that making sense to everybody? You guys, I don't know how to read this class. Drive on? So lymphoblasts, right? So again, we mentioned the T, right, going into the thymus. Typically, where do the other B cells go? Lymph, where else? Spleen and liver. Those are the three big areas. We're going to talk about this meninges here in a second, right? All right, more World Health Classification. Who cares so much? Hey, so again, age distribution, right? You saw on the other one, AML, it was all the way to the right. It was older. This is kids, right? Peak, 2 to 5 years. And then the adults that we talked about. Here's that Philadelphia chromosome, I'm saying this for the last CML, right? You have that weird variant that doesn't exist though with ALL. All right, clinical presentation. There you go. You start to have the bone marrow failure. The bone marrow gets crowded out by all these abnormal lymphoblasts that can't mature. So yes, my anemia, my thrombocytopenia, neutropenia, fever. All right, so fever from infection or fever from the leukemia itself. What are we talking about? All right, so fever from infection, we know, right? They're neutropenic, they got a neutropenic fever, right? And they're more prone to infection. But also, sometimes with leukemia, it's such a high turnover rate that the body has a very high metabolism. The basal rate is off the chart, so they'll spike up fever in absence of infection. It's just from the body working so hard producing all these extra cells. Good? Okay. All right. Lymphadenopathy, sure. We said that the cells are going to go where? To lymph nodes. So you can see some lymphadenopathy, right? Go to the B cells, also go to the spleen and to the liver, so you should get some hepatomegaly. T cells, we said go to the thymus. Where does the thymus reside? Mediastinal, we get the mediastinal mass. All right, CNS involvement. Go back to the slide, meninges, right? CNS involvement. Bone pain, sure. Just think about inside the bone marrow, all those cells, again, growing, reproducing. They start infiltrating the walls of the bone marrow, right? Could be painful, and these patients have diffuse bone pain. Diagnosis, similar, right? The labs, the anemia, the thrombocytopenia we talked about, the lymphoblasts, elevated uric acids and LDH. Cytogenetics, don't lose any sleep on that one. This one, CNS involvement. Mention it goes into the meninges. So this kid that you're seeing, right, because almost always a kid, ALL, if some of these cells end up in the meninges, right, badness, because sometimes the treatment doesn't penetrate there unless you target it. So you got to go get a lumbar puncture and make sure. Because you want to know, because you don't want this kid relapsing because we didn't target something because some cells were left over, right, in the CNS. You guys tracking? All right. Therapy, yeah, induction, consolidation, maintenance, got it. CNS prophylaxis, right? Again, do they have something left over, right, that's gonna cause them to relapse, you know, a couple months down the road, a year down the road, because we didn't target, we missed it, we didn't do a lumbar puncture on this kid. Prognosis, pretty good. All right, AML versus ALL, kind of what we talked about, right? So age distribution, one is elderly, one is young, one is blast, well, they're all blasts, and we're myeloblast versus lymphoblasts. And then with AML, you have that pathognomonic finding of ROIs. Any questions? ALL, lymphoblasts, myeloblasts. How do you tell them apart? How do you tell a lymphoblast from a myeloblast? Yeah, you really can't, right? They look the same. So what they have to do is like, you saw those like markers we were talking about, the flow cytometry, CD14, CD whatever. Certain cells have specific markers, so they have to do all the specialized testing. But just looking at a slide, unless I saw R rods, which say, okay, it's probably AML, it's myelogenous, just looking at it, you can't really differentiate a blast from a blast. A blast is a blast is a blast. All right. Hyperleukocytosis, what are we talking about? All right. So kind of, we talked about a little bit about with polycythemia vera, right? The hyperviscosity syndrome because of increased numbers of red cells in circulation. That's kind of what we're talking about here, right? You have impaired circulation. I got so many white cells, I almost have like a hyperviscosity type syndrome. Chemotherapy with leukapheresis. So this is bad, right? So now if they're getting headaches, confusion, or they're about to have a stroke, something bad about to happen. So do I need leukapheresis? What's leukapheresis? Think of it like, you know, think of it like a blood donation almost, where they're just taking off your white cells, right, to reduce your numbers. All right, that's the acute stuff. 2 flavors, right? Lymphocytic, myelocytic, right? Myeloblast, lymphoblast. Good. Any questions? Her?
Sir, I probably missed this, but is the hyperleukocytosis a potential complication of ALL or AML?
So either, yeah. All right. So chronic myelogenous leukemia, just by the definition, what do you know? Chronic. So this indolent, right? This is whatever drawn out. And then myelogenous, you know what cell line you're dealing with. Right? Myeloid cell line, right? All right. CML, we talked about the other day a little bit, or a lot. But really, Philadelphia chromosome, that translocation, chromosome 9 on 21 produces this Philadelphia chromosome, right? That BCR ADL fusion. And what does that chromosome do? What does that abnormal chromosome do? What is it affecting? What was the commonality between all the myeloproliferative disorders? What did they have in common? Tyrosine kinase, right? That JAK2, right? So this abnormal chromosome basically puts its foot on the gas on this tyrosine kinase that's telling these cells to reproduce. Chronic accelerated blast. So think of it as this triphasic. So most of the time, right, if you're lucky, you catch them in that chronic phase, they're just kind of humming along, tend to be asymptomatic or mildly symptomatic. Your blasts are less, okay, so we talk about, hey, greater than 20, less than 20. What's normal blast? Normal patient, what's reasonable to expect on a cell? So 2 to 3% is kind of, we say, hey, normal, right? So chronic phase, yeah, blast, whatever, right? Certainly less than 20%, probably less than 10. Accelerated, now they're kind of that 10 to 20 phase, right, of blast. And then once they hit the acute or the blast crisis, now you're at greater than 20%. And there again, age, right? Who does this hit? Median age, 55, right? Uncontrolled production, maturing granulocytes, right? neutrophils, basal, eosinophils. Not uncommon to see a high number of basophils in these patients, right? Okay, this is affecting your granulocytic line. What comes off of your granulocytic line? Neutrophils, eosinophils, basophils, right? So that's what you're affecting. So that's where you see the bump. Fatigue, weight loss, night sweats. Why fatigue? Anemia. Why the weight loss? These are hallmark cancer, right? All your cancer patients, right? You're doing your review of symptoms on your patient. We gotta speed this up. You're doing right? You always ask these symptoms. Hey, any fevers, chills, night sweats, weight loss. Where's the weight loss come in? Right? You have such a high turnover rate. The body's using everything it can to produce these cells. So it's sucking everything from every place else, right? So they get the weight loss and the night sweats. Splenomegaly, good. Accelerated, yeah. So again, right? If you're gonna see them going from that chronic phase, you start to see more blast cells. You know it's moving in the wrong direction. Marked leukocytosis, basophilia, right? Bone marrow, sure. And we talked about that BCR ABL gene, right? Treatment. We said, hey, the problem set here was that tyrosine kinase is on and can't turn off. So what do I need to do to treat it? Turn it off. I inhibit it. Yeah, I can't shut it off, but I can inhibit it somewhat, right? So tyrosine kinase inhibitors. This drug in particular, imatinib, that was like a big game changer in treating these disorders. That's a prominent drug that you're going to see again and again, and you'll see people on it. Excellent, yeah, with TKI, right? Tyrosine kinase inhibitors. All right. Quick chart, chronic, accelerated, your blast phase, and you can kind of see. So yeah, typical 2 to 3%, certainly less than 10% in that chronic phase, right? Kind of accelerated, more than 10%, and then one greater than 20, they've now slipped into blast crisis or your acute phase. All right, we're almost there. CLL. You know what the problem set is, right? Indolent phase, chronic. A lot of patients continue their life in CLL. Just Charlie, Mike, and keep moving. Pathophys, proliferation of mature B lymphocytes. Chronic, we said mature cells, right? And here we're talking specifically with CLL, it's the B lymphocytes. Uncontrolled production, like everything else we mentioned. So indolent phase. And we'll talk about this on the next lecture when we talk about the lymphomas. But it's kind of like the same disease, there's a continuum where these B cells, these abnormal cells, go into the lymph and produce a lymphoma, right? And I got a cancer in the lymph. But we'll talk about that more next lecture. Most common leukemia in adults. Family history, right? So strong predictive. If I've seen a patient and you're doing your review on them and you're getting your history and say, oh yeah, well, you know, my granddad had CLL and this patient is now complaining of fever, chills, and weight loss and night sweats, you're like, oh crap, right? There's a family history kind of thing there. Clinical presentation, right? It's this indolent phase, right? They're CLL, so they're often asymptomatic. Sometimes it's just, man, I ran a CBC on this dude and I got this crazy white count. I don't know what's going on. So I'm just going to ignore it and tell him go see the next guy. Wrong answer. Right? Again, we call these the B symptoms, right? Fatigue, weight loss, night sweats. Usually when they're having these kind of symptoms, right? So we said, hey, it's often asymptomatic, but this usually tells me that the disease is going in the wrong direction. Lymphadenopathy, cervical, supraclavicular. Right? Again, these B lymphocytes go to where? Where do B lymphocytes go to live? Lymph nodes, liver, spleen, right? So they get lymphadenopathy. Recurrent infections due to hypogammaglobulinemia. Somebody talk to me about this. What's going on? All right, what's the gamma globulins? So IgG, right? So they're antibodies. What's the job of normal B lymphocytes? Produce antibodies. Right? So if I got a bunch of cells here, right, that are abnormal, so again, right, we say that these cells are mature, meaning they're not blasts. But let's just kind of talk this through a little bit, right? So again, your blast cell, progresses down to a mature cell, right? So a mature lymphocyte. When we talk about CLL, right, what's the definition of cancer? Go back to the very what's the first step in cancer? You produce an abnormal cell, right? So even though this cell is working towards being mature, right, it's not quite there, right? So it might be a little bit before full maturity, or even if it matures, it's not completely functional. Right? There's something wrong with this cell, right? So we're saying mature cells is chronic, but just understand that that cell is not quite normal. It's a cancer cell, it's not normal. So it means it's not fully functional. And we say the job, let's drop something. The clicker. Thank you. So we said the job of a mature B lymphocyte is to do what? Produce antibodies. If I have a cancer cell that's not quite fully mature or not fully functional, I'm not producing antibodies sufficiently. So I get hypogammaglobulinemia. Everybody good with that? Yeah?
So just time check.
Why do you guys get, we're almost there, we're almost there. Thank you. All right, so hypogammaglobulinemia. The other thing is, here, immune hemolytic anemia. So sometimes they produce jacked up antibodies that attack your own system and you get an immune hemolytic anemia. Again, these are not normal B cells. They're doing their best to do their job. They're saying, I'm gonna try, but maybe I'm not producing enough. So I get hypogammaglobulinemia, or maybe I end up producing a defective antibody and I target my own friggin' system. Good? Ish? All right, there we go. Hallmark, isolated lymphocytosis, right? Huge amount of lymphocytes, right? I'm dealing with that. Smudge cells, let's talk about the smudge cells real quick. So again, these cells aren't completely normal. They're a lot more friable than a normal cell. In the lab, did you guys make smears? Talk about it, all right? So you're gonna do a peripheral smear. Again, poor lab tech puts a drop on a slide, takes another slide and skates it across the blood, smears it. These cells, because they're not fully normal, they're not as structurally strong, they smudge. They break apart. So if you get a differential back and you see something with smudge cells on there, like alarms and bell whistles, right? Because you shouldn't see smudge cells. All right, flow cytometry, who cares? Immunophenotyping, that's just again to kind of help them narrow it down so you know what you're treating exactly. Bone marrow increased, right? Hypercellular, because you're producing all these extra cells. Not required for diagnosis. All right, asymptomatic. Sometimes it's okay to do nothing. There, I said it again, feel better, right? Asymptomatic, it's okay to observe. If they're symptomatic, treatments, sure, got it. Complications, we'll talk more about Richter transformation when we talk about the lymphomas, but this is basically these cells go into the lymph node, they undergo another mutation on top of the mutations that already went, that make them sort of sticky, and now they all form in these lymph nodes and form a very aggressive form of a B-cell lymphoma. And that's that Richter transformation. All right, we made it. All right, so again, think of it, AML versus ALL, both acute. Which lines are affected? Myelogenous versus lymphoid, and then chronic versus CLL versus CML. Hallmark of CML is what? CML, Philadelphia chromosome. All right, if you have any questions, come yell at me. Management, refer to